So again, I am going to have to fess up and say that I was looking at the wrong film when I was looking at these results, and it is actually acute lymphoblastic leukemia. So that is how hard it is to tell the difference between myeloblasts and lymphoblasts just by looking quickly at a blood film. So yes, it is a brain implosion, and it is very, very difficult, which is why I don't expect you to be able to do it. So yep, Z gets the prize, and Amelia gets the prize too, and Jordan, I apologise most profusely, because they did look like myeloblasts because they were quite pleomorphic. And so it just goes to show that that's why I don't want you to worry so much about being able to differentiate them. Okay, my main thing is that you can see blast cells. Okay, so I think we need to, yes, it is Kiani, it's ALL. So sample code 4.8.1, well, it's query ALL. That's what we've got on the notes here. And the thing about that is that often the myelodysplastic syndromes can transform into ALL. And so that's why with our acute leukemias, it is so important to do the immunophenotyping. Yes, Amelia, you're quite right. It does look like MDS at the same time because remember, myelodysplastic syndrome, you've got those dysplasias happening with the white cells. And so I think as Jordan pointed out, the cells look quite agranular because we found this beautiful pycnotic neutrophil. So that meant that's, and everyone should have seen it about at 2 minutes 15, wasn't it? Sorry, 2 minutes 50 on that film. And so it showed you the neutrophil with very definite multiple lobes that just looked really weird. And that was a pycnotic neutrophil that did not have any granules in it. So with myelodysplastic syndromes, you often don't get those granules. Okay, so you do sometimes get a macrocytic anemia, Gabby, when you're looking at these films, and that again is part of, particularly in a previous myelodysplasia, you often get macrocytosis in a myelodysplasia because you get a megaloblastic blood picture. So that's quite common with MDSs. If you go back and have a look at your notes about them, macrocytosis is one of the things that you can see. So this is in fact an ALL or query ALL, and the majority of cells that you see here, 73% on my notes, and of course that's different to the video, but 73% were blast cells, and 16% neutrophils, 4% lymphocytes, 6% monocytes. So the majority of the cells that you saw in that video were blast cells, and you would have seen an occasional neutrophil, perhaps a more mature lymphocyte, and there were actually myelocytes recorded. There was one myelocyte recorded, so Jordan, the cell you saw could well have been a metamyelocyte. So that's why it says query acute, query ALL. But the main thing when you are looking at your summary in your provisional diagnosis for this film, first of all, what would you write for the red cells in your summary? So summary of the significant findings. Remember, we always write about the different cell lines. So while somebody's typing that, I'll answer Jordan's question. Yes, macrocytic normochromic anemia or just macrocytic anemia is fine. So what would we say about the leukocytes? What is significant about the white cells? We have a leukocytosis, yep, and what else is significant about the white cells? Yeah, many blast cells, so that's what you'd write, leukocytosis with many blast cells. Yep, Greater than 20% blast, that's a really good one, Max. I like that. Okay, what about the platelets? Beautiful, thrombocytopenia. So there is your summary of the significant features of the blood film. Okay, right, now what is your, if you see dysplastic change, yes, make a note of them, Adeline, that's fine. Yes, you could say that, that's fine. The thrombocytopenia is really the main thing there. If the morphology is dull, probably don't need to, but certainly I wouldn't take marks off you for doing that. So what's our provisional diagnosis here, guys? Lovely. And not just acute leukemia, but I would put query acute leukemia. Okay, because a provisional diagnosis, you haven't done anything to definitively diagnose it. So it's query acute leukemia, or could be acute leukemia, something like that. Nice and broad. And then if you wanted to, you could have a stab as to whether or not it's ALL or AML. But as you've just seen from me, it is very difficult to tell the difference between them. Okay, so that's our summary and provisional diagnosis. And then the further diagnostic tests that you would do. So we know that we would do immunophenotyping, and I think that Jordan did ask me a question up here. The immunophenotyping results, because we don't focus that much on immunophenotyping for our mature neoplasms, particularly the mature myeloid neoplasms. Sometimes they are of use with the mature the mature lymphoid neoplasms, as we will find out next week. But so the fact that you've got an MDS there, you would expect just if there's a transformation to ALL, you would expect just to see the ALL CD markers. And so in this case, what sorts of NS is mature, Jordan? Yes. So the myelodysplastic syndromes are mature, the myeloproliferative syndromes are mature. Okay. For the precursor syndromes, you either have acute in the title, or you have blastic in the title, or you have precursor in the title. Okay. In this case, Luke, as I said, particularly the fact that this person has a previous myelodysplastic syndrome, but sometimes we do get that increased MCV. So you do get, it's just showing the dyshematopoiesis that's within the bone marrow. Okay, so in this case, it's not a significant feature. And remember also that when we have these neoplasms, that you do have competition for nutrients. So, I mean, there could be a bit of a nutrient deficiency, but it's really not the main feature here. The main feature, and the thing that they will be wanting, that the clinicians will be wanting to treat, is the fact that there are blast cells there. Okay, so the treatment would focus on reducing that malignant clone, so that then the normal bone marrow can come back. And then it may well be that part of the supportive therapy, once they have treated the clone, is looking to providing nutrients, making sure that the person had a really good diet, and providing additional nutrients if they need to. But it's mainly about identifying the blasts, so that is the focus of the treatment. And that is a good question, because when you're looking at these sorts of syndromes that you've learned about in the second half of semester, the majority of them do have an anemia associated with them, because they're all myelophasic anemias. And it is working out what is the primary feature and what needs to be dealt with first. Okay, and whenever you think you've got a neoplasm there, that has dealt with, unless the person is obviously affected by their anemia, then they may well transfuse. But depending on how low that hemoglobin is, they may just be focusing on the white cells and using transfusion as supportive therapy as needed. So what sort of immunophenotyping do you think we'd see here? Cytochemistry is usually used to differentiate between myeloid and monocyte. So if you think you've got an AMML, so an acute myelomonocytic leukemia, or an acute monocytic or monoblastic leukemia, then your cytochemistry comes into that can be quite useful there. Certainly, if your immunophenotyping is your first port of call, and you will be looking to suggest the CD markers that will show you whether or not you have got an ALL or an AML, and if it is an AML, what the maturation level of it would be. So the cytochemistry results for between the myeloid and the monocytoid lines are things like Sudan black B, myeloperoxidase, and the non-specific esterases, or the esterases that are there. I can't remember them off the top of my head. Sudan black B and myeloperoxidase is for the myeloid line. Very early myeloid cells are negative for both of those, so you do have to watch that. And then the esterases are positive for the monocytes. If you have a look in RODAC, it can give you some more information. So in your clinical atlas, it talks about the cytochemistry. But we do rely, particularly when we see blasts, our first port of call is the immunophenotyping. So can anybody remember what immunophenotyping we would expect for this to be a BALL? Okay, so we've got a lot of the CD markers up here. Well done, people. Because it is an ALL, so that is an earlier form of lymphoblastic leukemia, certainly CD19 and CD10, because they are the lymphocyte markers, and they're found on the early cells. CD20 and 22 are found on the more mature cells. So Gabby will be looking at them next week when we look at the mature lymphocytic syndromes. Bone marrow biopsy is the preferred material that's used, Z, although depending on the white cell count, they can use peripheral blood, particularly if it's a high white cell count, then they'll use the peripheral blood. But in most cases, bone marrow biopsy is applicable, particularly with the lymphoblastic leukemias, because often, see, this white cell count in this one is 26.4. which threw me a bit because it's usually not that high. Usually with our lymphoblastic leukemias, they're sort of more normal in their number. And so the clinicians like to, or the haematologists like to see the difference between what's happening in the peripheral blood and what's happening in the bone marrow, because the lymphoblastic leukemias can be a bit tricky that way. So usually bone marrow biopsy is done just to check on what they're seeing in the peripheral picture. And so because they're doing the bone marrow biopsy in aspirate, they often send that material away for the CD markers. So what about the earlier markers? Don't forget about CD34. Again, Gabby, the Kappa light chain and Lambda light chain are probably more to do with more mature markers, as we will see next week. Okay, so just trying to have a look at I've got two screens up, so you'll just have to bear with me for a minute. What else have I asked you? Okay, that seems to be all we have asked for that one. So we'll go on to, unless anyone's got any more questions about that one, we'll go on to sample code 7.9. Yep, everybody happy? We'll go to 7.9. What did you think of this one? Yeah, it's probably, so what makes you think it's a leukemoid reaction, Amelia? Okay, so high reactive lymphocytes. That's a good point. It's well spotted. Usually with our leukemoid reactions, we reserve that for when we've got a neutrophilia. And so the leukemoid, differentiating the leukemoid reaction from CML is usually what we do. So when we've got an increased number of lymphocytes, we don't tend to refer to that as a leukemoid reaction. We keep that for our neutrophilias. Okay, but it's a good point. Well done. So again, this is in fact a somebody who has got glandular fever. Just trying to get hold of my notes again. So we're just going to have to go with this one. That's fine. Yeah, so it is somebody who's got glandular fever, and the lymphocytes that you're seeing here are indeed reactive lymphocytes. The population at risk is indeed kissing teenagers, Jordan. And that's why I put this one in, because it is a 36-year-old. And so they are not your typical population for glandular fever. Okay, but I mean, you know, this person may be somebody who interacts a lot with people. This person would indeed be a kissing adult, yes. Okay, so just be aware and remember, I mean, keep in mind the population at risk, but they are the most common group that is affected. Okay, so as you've seen in this case, as I think everybody has identified, the lymphocytosis here is in fact due to glandular fever, to reactive lymphocytes rather than lymphoblasts. And that's really what I wanted you to be able to differentiate between the reactive lymphocytes and the lymphoblasts, which you were able to do. So that's fantastic. So has anybody got any questions about 7.9? I think it's fairly straightforward, wasn't it? So again, defining your significant features. So what would we say about the red cells in this case? Yeah, so further tests would be viral serology and an IM test. That's quite correct. Yes, and their normocytic normochromic blood picture. Remember, because it's not an anemia, this person. And again, that's a good indicator that this is probably not a neoplasm because we don't have an anemia. Okay, what about the white cells? How would you summarise the white cells? Lovely, leukocytosis with the presence of reactive lymphocytes. That's fine. Okay, and the platelets should be normal. So you can say, you know, with normal platelets. For question 3 and question 5. Okay, so summarise the significant features of the results which you have just done and suggest a provisional diagnosis. So what would your provisional diagnosis be here? Remember, we keep our, so that's very specific, Jordan. So remember, with our provisional diet, lovely. So viral infection is better because it's nice and broad. Okay, and then you can say in question 5, then you could say the condition most likely for these results is the Epstein infection with the Epstein-Barr virus or IM or glandular fever. Okay, so again, it's a good idea when you are answering questions, exactly, more specific in question 5, when you're answering questions that you read ahead to make sure that, again, that you are adding the detail that is required for the question, okay? Because it may well be, you know, just scan down through your questions and just see, okay, I need to be more general for question 3. I can be more specific for question 5. Okay. What about question 4? How would you justify your provisional diagnosis of query viral infection? Okay, so presence of high reactive lymphocytes. Okay, so, and Jordan, yours is quite good too. So you could probably say, again, you may not need to be that specific. Again, I would not mark you down from that. Yes, reactive lymphocytosis can be seen in other viral infections, Amanda. That's the really important point. So that's why you go query viral infection, because you obviously don't recall, but in week 8, we had a look at another case study. Remember, I think we've talked about this before. The person actually had diarrhea, and there were reactive lymphocytes in that blood film too. They were different to these ones, but they were still classed as reactive lymphocytes. So you can get reactive lymphocytes in many viral infections. The ones that you get in glandular fever do tend to be fairly classic to glandular fever. So they do tend to be, and that's where the term, you know, the atypical mononuclear cells came in that I used to use, but these days we tend to refer to them all as reactive lymphocytes. So that what you see in the blood film here in film 7.9 is fairly typical of the reactive lymphocytes that you see in glandular fever. But that would be part of your justification, you know, that you've got an increased number of reactive lymphocytes. Reactive lymphocytes are seen in viral infections. Okay, so that's that would be your justification there. And you could say, Jordan, that they are not, you know, they're reactive lymphocytes, they're not blasts, you know, something along those lines if you want to. And as I said, you certainly wouldn't be marked down if you went to that degree of detail, but really all I'm wanting. I can't say in 100% of the cases, Z, but it is one of the features of reactive lymphocytes is the fact that they do tend to sort of ooze around the red cells. And the other thing too that they often have is that the cytoplasm sort of folds over on the edges, and so you get sort of little dark bits of cytoplasm at the edges as they're folding over. So I think they're a lot more active. They're probably a lot more, what's the term, amoeboid in their look. And that's why, if you recall, I said that when I was in the lab, we used to refer to them as atypical mononuclear cells because they're very difficult to tell the difference between the reactive lymphocytes that you see in glandular fever and monocytes, because you can get a monocytosis in glandular fever too. So, yeah. The main thing to get from this, the take-home message from looking at these two blood films is that you are able to differentiate blast cells from reactive lymphocytes. Okay, because when you are querying an acute leukemia, one of the differentiating tests you could do before you go ahead and do a bone marrow is a test for glandular fever, you know, because a spot test for glandular fever, or go back and check the patient's history to see if they possibly could have a viral infection, because you do need to differentiate those two. But in any laboratory, if you think that you're seeing, you know, that the analyzer has picked up a sample that's got blast cells in it, that would go straight to the haematologist, and the haematologist would then make a call as to what the next steps were. So you wouldn't have to make that call, but that's why it's important for you to be able to tell when you've got blast cells there. Okay, so further tests required, yeah, viral studies, test for glandular fever would be a further tests that you would do there. Has anybody got any more questions about case 7.9? Okay, doesn't sound like anything's coming up in the chat box. Has anybody had a chance to look at 7.10.1? No, not yet. Okay. Okay, so let me see, what else have we got to do today? Okay, so I'll let you go away and have a look at 7.10.1. That's just a really quick one. Jordan's obviously just opened it up. And have a look at sample code 4.4.1. And again, just do a 50 cell diff on that one as well, because it'll just be quicker for you to do that. Okay, so is the MCV normal? Yeah, it is normal, isn't it? That's interesting. But look at the MCHC. So remember that the MCV is calculated. Sorry, no, it's not calculated. It is measured. So I don't know why the MCV is normal, but it's the MCHC that really gives it away. Yeah, it's interesting, isn't it? So that is why we, when you're looking at 7.10.1, the MCHC is 485, which is very, very high. And normally we only get that if we've got agglutination of the red cells that's there, or whether, or we might have, you know, clotting of the, you know, blood clots, which would also agglutinate the cells. Yeah, so I don't know why that is that. You would expect it to be higher. It could be that as it goes through the flow cytometer that the agglutinates are broken up. That's the only thing I can think of there. The hemoglobin and the hematocrit is what we make that from. So the hematocrit, the hemoglobin is normal and the hematocrit is low. So it could be that perhaps the agglutinates are not, they're not lysing as well as they would normally, and so they're going through the spectrophotometer and they're given a higher reading for the hemoglobin. No, that's not, that's the MCV. That's not going to affect that. Yeah, I don't know why. And unfortunately, we used to have blood film 7.10.2, which was a warmed sample. So if you get an MCHC of that high, what you would do is you would ring the ward and you would ask them to take another sample of blood from the patient, and you would keep the sample warm all the way to the lab. So they'd either put it in their hand, take the sample from the patient, put it in their hand, or somewhere on their body that's warm. I have known women to put it in their cleavage to keep it warm, and take it down to the lab and put it into the 37-degree water bath. You can warm up the existing specimen, but sometimes it doesn't work quite as well. It depends. And then put it through, and then what you'll find is that the MCHC will come down to normal, and the hemoglobin and the red cell count will change as well. So the hematocrit is actually calculated from the MCV and the red cell count. No, MCHC is hemoglobin and hematocrit. Yeah, I don't know why. That hematocrit is quite low and the hemoglobin is normal, so there is something, that would change. The hemoglobin would come down, the hematocrit would probably come up, and the red cell count would come up as well. But yeah, just to make a note of the fact that you've got an increased MCHC there, which is telling you that you've got cold agglutinins there. And that is quite common in glandular fever. So you can sometimes see occasional spherocytes, and you can sometimes see occasional small agglutination, red cell agglutinates in there. I don't know that any were present in sample code 7.9. To be honest, I didn't look that closely for that one. I was looking mainly at the white cells. Did anybody see anything, any spherocytes or any agglutination in sample code 7.9? Nope. Okay, so nobody saw it. That's fine. Occasional spheros, yeah, could be. So you don't see it in all films. It depends. It's just that in some films you'll get an increase in auto-anti-big eye that causes the auto-agglutination, especially at cooler temperatures. Okay, so that's sample code 7.10.1 covered, so that's good. Okay, so if we go on and have a look at sample code 4.4.1 now, and again do a diff on that and see what you think. Okay, so what's the time now? It's 11:27, so I'll give you half an hour on that. So if we come back at 12 o'clock.